Dr. Patterson, if you look right into this camera for me, say your name and your position here.
Sure. James Patterson. I'm the chair of the Department of Psychiatry and Behavioral Medicine.
And now you can look at me, Doc. The nation faces a mental health crisis, but it's particularly acute here. Why is the mental health crisis in our community so severe?
Well, there's more than one reason. As usual, it's multifaceted. One of the biggest problems we face in our society here locally is not the opioid crisis that you've heard of, and obviously it's COVID. COVID is everywhere, but it's methamphetamines. It's one of the biggest problems we have. And that especially impacts us, not just because it's prevalent, because we have a significant poor population, a low socioeconomic status population here in Shreveport. So it can get pretty bad.
Why has the mental health crisis got at such a critical stage, though, in this city?
Sure. Well, it's been expanding. 20 years ago, we were seeing 3, maybe 4 or 5 patients a day in the ER with psychiatric emergencies. Now it's 10, 15, 20, 25, 30 per day that are coming in with psychiatric emergencies. Now, we don't have more people. In fact, the population of Shreveport and Catawba Bossier area has gone down about 2%. It's just more people that are sick. And so my own theory about this, my own research on this shows that it's basically repeating cycles of being, not just poor, but broken families. People who from a broken family grow up and go through the same cycles of abuse and drug abuse and neglect and broken education and jail and violence. And they have kids that are raised in that same environment, and they grow up and have kids. And so this has been going on now for several generations.
You and I talked, and I asked you the question. I'll ask you again. As we see, obviously, the population that's suffering mental illness, suffering through psychiatric emergency grows. Is there a threat that we could lose almost an entire generation to mental illness?
I would definitely say that's a possibility. We have, it's something that is near and dear to my heart because I see it every day in the ER. The number of kids we have coming into the ER is increasing now. And so it's getting younger, it's getting more severe, and it's not going away.
Let me ask this question first. You used the term, for the first time I heard it was when you and I spoke last week, a psychiatric emergency.
Sure.
What is a psychiatric emergency?
Sure. So psychiatric emergency psychiatry, as it's called, I used to make a little joke about that. It's like, so people would ask me, do you have a couch in the emergency room? And the answer is no. I do very little psychoanalysis or couch work, as they call it. I take care of people who are suicidal, who are intoxicated on drugs, who are gravely disabled because of psychosis or withdrawal from drugs or intoxication on drugs, or for some other reason. So typically it's not one of the above, it's several. So someone who's strung out on crystal meth, for example, who's now psychotic, depressed, and suicidal, on top of being homeless, has no job, and has criminal charges pending.
When you see someone that comes into your ER, if you can describe in the most, and I know there's no generic way, but what's happening to this person typically when they come into your ER and when they're suffering a psychiatric emergency and you see them in your ER, what's happening?
Many times, and again, it's varied. So we have people that walk in that are depressed and suicidal. Had one walk in today who's pregnant, depressed, and suicidal because she's off her medications. Many times the police will bring us patients who are psychotic and withdrawing from drugs or just schizophrenic. In other words, they have a true, real, non-substance related underlying psychotic disorder like schizophrenia or bipolar. And they aren't taking their medicines, or they need to be on medicines and they need help.
A crisis is defined as a turning point for better or worse in the treatment of a disease. When it comes to this mental health crisis, which path are we on? The path of getting better or the path of getting worse?
I would have to say worse. We're not doing enough. One of my favorite ways of characterizing where we are right now is putting a Band-Aid on an arterial wound. We simply do not have the resources, especially here in Louisiana and especially here in Caddo Parish, to deal with the influx of patients. We're growing, we're amplifying. I think at least that Ochsner is finally realizing how much help we need, but I think we can do more at the state level.
You talked, and you mentioned that putting a Band-Aid on a wound. It's like we're triaging a gaping wound instead of then moving on to treat this. Explain that discrepancy.
Sure.
To me.
Well, like I said, if someone comes in and they're withdrawing from crystal meth, they're psychotic, we can get them to the point of not being psychotic. We can get them to the point of not being suicidal. We can get them stable enough, and then we discharge them. We refer them to substance abuse treatment. Sometimes they go, sometimes they don't. The best way for substance abuse treatment to work, it takes about 2 years. It's not 2 months, it's 2 years. And it's an incredible time investment. And crystal meth is one of the most, it has been characterized the world's most dangerous drug. And we aren't doing enough to stop it because it's incredibly addictive.
When we talk about issues of substance abuse, alcohol, drugs, do you see a lot of the patients that are suffering from mental illness, psychiatric emergency, using substances, using drugs, using alcohol to medicate because they're not in the mental health system now getting appropriate treatment?
Well, certainly we do see some of that. And it's really, really problematic when someone who has schizophrenia or bipolar goes out and uses a drug that will make you very, very sick on top of that. And we do see that. Patients who have severe mental illness like that oftentimes don't really have good insight and good judgment, and will do things that will make them very sick. We have plenty of those patients up on the 10th floor psychiatric inpatient unit. And a lot of them, and that's one of the reasons why we're expanding into having a better, nicer, larger facility.
I was reading through your PowerPoint presentation, and I was alarmed to read there have been instances in the past when you've had to shut down the ER because it's been overrun with psychiatric patients?
Back in the day, yes, absolutely. Before our psychiatry crisis unit, and before the ER expanded, our ER would shut down to everything except the most acute trauma, because we're a level 1 trauma facility. We can't shut down to that. But everything else we would have to shut down.
Tell me about your 10th ward, or your 10th floor.
So the 10th floor psychiatric inpatient unit is our current inpatient psychiatry service. And that's where we put patients with severe mental illness who are in need of further stability, so that our criteria for admission there are fairly straightforward. You have to be suicidal, homicidal, or very gravely disabled. Typically, we don't deal so much with homicidal ideations. That's something that, that might get them into prison. But sometimes there are.
On any given day, how close are you to capacity?
Oh, we're always at capacity.
You're always at capacity?
We're always, yeah. I would say we're at 100% capacity 98% of the time. Well, if we have a bed open, we fill it within hours usually.
What happens if all those beds are full and someone comes in?
So the psychiatry crisis unit is where we board patients. And so in that same PowerPoint I showed you, there was an article about boarding of psychiatry patients in the ER. And sometimes that 17-bed facility fills up, and then we board them in the emergency room in what's called the 40s, in room 40 through 48. Sometimes those fill up, and we have to move them into the rest of the ER.
What does boarding mean?
That means they stay there. They're waiting on a bed. They're waiting on getting better. Oftentimes our patients that come in a bad state, typically drugs, withdrawal, they will clear up in 2 to 3 days. And so they need to stay for that long. And by the time a bed is ready for them on 10, I'm better, I need to go home, I've got a job, and that kind of thing.
Does that happen often?
Every day.
What's going to happen? That person walks out the door at that point.
Well, they often do go out and get better and stay clean off drugs, but sometimes they go back, and so we have many patients who are revolving door patients, I think is what you might characterize them as.
Do you have any idea the percentage of those patients that might be revolving door?
Oh, I'd say probably 10%. And it depends, because a lot of them are not, some of them will come back the next day. Some of them will come back in a week, some of them in a year. Many of them we've seen before, once or twice a year, 7 or 8 times a year, and so it varies.
Dr. Patterson, how long have you been here serving and treating mentally ill patients?
I've been in Shreveport for 20 years.
In that time, and we were talking about on the 10th floor and folks that you're boarding in the ER and in other parts of the hospital, how many patients, what's the most number of patients you ever recall seeing being treated at one time in this hospital for mental illness?
That's not very long ago. About a month ago, our inpatient unit was full, and we had over 30 patients downstairs. So they were, the ER, the psych crisis unit was full, the 40s were full, and so that's not unheard of. That happens sometimes every few months.
How many patients is that?
Total of 37 plus 30, so 67, probably close to 70. Yeah.
Do you think we understand that in the community?
No.
The level of this crisis?
No.
Why not?
No.
We hear so much right now that mental health's being destigmatized, that
It
we
is.
understand better and folks are better educated. But if that's the case, why are we still seeing great numbers of people suffering and the system seeming to fail?
I think, and that's a great question, and I think the answer is that you have a society that is already hurting COVID. It's already hurting unemployment. It's already hurting for X, Y, and Z. And they really don't want to look at other people's problems or what they perceive as other people's problems. It's a community problem. It's going to affect everybody here eventually. And if you break a leg or an arm and you come into the emergency room, it will affect you because it will increase your wait time. And that's another reason that we keep expanding and keep adding beds and keep, adding more units. And that's what we're doing. But it's important to realize that is that the answer? And I don't think it is. I really think we need to look at different places, and we have to, and I know this is an old phrase and it's a catchphrase, but we have to think outside the box. And because what we're doing is not working.
What are some of the solutions if we stop and start thinking outside of the box?
Our families are broken. They really are. And it's not just broken families. My mom and dad were divorced. That's something that is pervasive, ubiquitous in our society. We have to start educating children early. We have to start training children early. And sometimes the families that should be doing this aren't. And so somehow, somewhere, we need to get that resilience training, that starting very early with children to prevent this from happening. Because by the time they get to my emergency room, it's too late. We can put a Band-Aid on it, but it takes a whole lot more work to fix it and repair it downstream and to prevent it from happening to their kids than it does to start early with the kids that we have now.
Reading your PowerPoint, I got the impression that treating mental illness, there's been a shift away from hospital-based treatment to a more community-based care. Have we basically, in our lifetime, torn down our mental health system and moved to more of a patch quilt work type of system that's just putting some of the most sick people back out into our community?
Sure we have. I think the pendulum is swinging back, but after it's a really big word, deinstitutionalization happened in the 60s, 70s, and 80s. After that, managed care basically cut what psychiatry would be paid for by a huge amount. They stopped paying. Nobody would pay for substance use disorder care. Now they've changed that. So now mental health parity has happened, but it took a couple of decades. Even after mental health parity, paying for substance use disorder, parity for addiction, that didn't happen until recently. And so even now, it's still very minimal in terms of what our society is paying for. And so it's important to realize that they're paying for it on the other end. It's being paid for somehow, just not through health insurance.
And the reality of that situation is we're at a point in time in this crisis where so many of the people suffering mental illness, their first contact with mental health help comes at the hands of police officers. and then the emergency rooms. Are these people in institutions that are actually prepared to deal with someone suffering psychiatric emergency?
No, no. In fact, most emergency rooms, especially rural health emergency rooms, they don't have any psychiatric help. I can remember in Alexandria, for example, when we were working there, we would come in on the weekend and they would have patients waiting for psychiatry to get there several days because they didn't know what to do with them. And that is still going on today, and it's going on in higher numbers. There's simply a shortage of psychiatry and an overabundance of patients that need emergency psychiatric help.
What about the issue, the concern of police becoming
Much more involved. Many of our patients are brought in by police. Many of them start their trip to the emergency room via police. And the jails are full of patients that did something wrong that really have an underlying mental disorder. We know that's true. We have forensic psychiatry services that help treat those patients, but it's really hard to have what I would call the best care for somebody when they're in jail. And so if you're psychotic and you do something wrong and you get arrested for it, is that the best care? No, it isn't. Obviously, we try to keep people from being psychotic. We can't always do that. It's hard, especially when people don't take their medicine. It's a tough problem.
What risks are posed to a person suffering a psychiatric emergency or a mental illness when they come into a contact, have an incident with police? Is there the risk that this can escalate quickly if officers aren't properly trained?
Sure, absolutely there is. There is very big risk because if a police officer tells somebody to do something and they don't have a good contact with reality, they're psychotic, they may just keep doing what they're doing and ignore the police officer. The police officer then does what they have to do that could get violent, aggressive. There could be harm to them, officer or the patient.
How important is the crisis intervention training for police officers in this community?
It's incredibly important. I wish we had more of it. We need more of it. We've had some, which is good. So yes, it teaches police about patients with mental illness. It really does, so that they can have an understanding that certain behavior patterns that they see aren't volitional.
I got two quick questions. One, are we criminalizing the mentally ill today?
Yes.
You talked about one thing, and if you can briefly, an idea that you have in finding diversion programs for those suffering mental illness that come in contact with police. What would that look like?
It'd be wonderful to essentially have someone who at the point of arrest for something get into a diversion program, not just for drugs, but also for mental illness.